Okay, so we left our heroes PEEPing our patient. Everybody bought into PEEP now?
Sure.
Yeah, sure. Buy it? Works?
So.
Yeah. You guys peeping right now? Yeah.
Every chance we get.
Everybody peeps.
It's the new hotness.
Everybody peeps.
It's the new hotness.
It's the new hotness. PEEP is the new hot, right? Yeah, everybody peeps all the time. About 2 to 3 centimeters of water, natural intrinsic PEEP, which, by the way, you lose when you put an endotracheal tube in through the vocal cords. You lose intrinsic PEEP. So it's one of the reasons that intubation isn't the solution for everything. Yeah, it secures an airway. The only thing that's going to go into those lungs is whatever goes through that tube. But as Dr. Kempema is fond of saying, intubation isn't just about putting plastic between the cords. It's about understanding what you're doing to the patient and then what you need to do to follow them up as far as ventilation, appropriate ventilation, PEEP, volume and rate settings, medications, everything that you need to do. It's not just sticking plastic through the cords. You can teach a monkey to intubate somebody. Somebody probably has. Okay? I don't think, if you could teach a monkey to do ventilator settings and all that fancy stuff, they could take my job. Not okay with that. So once Coco starts, messing around with sophisticated ventilation equipment, I'm messed. So everybody peeps, and there's advantages to PEEP. We already talked about these, but let's read them in geek speak on the overhead here. It increases airway pressure, back pressure, prevents airway and alveolar collapse. Anybody know the fancy word for alveolar collapse? I'll give you 2 stars if you pull it out. And if you don't, I'm not going to say it because it's not important. Don't worry about it. De-recruitment would be something that maximizes recruitment of alveoli by preventing cyclic de-recruitment on expiration. We'll hold it at that for now. De-recruitment of alveoli, the collapse would be a bad thing. And I skipped over, increases the capillary alveoli interface for gas exchange, reduce ventilation perfusion VQ mismatch, improves the distribution of gases, and as a result, increases the work of or decreases the work of breathing. So, all good stuff that PEEP does. Now, PEEP is not all glitters and sprinkles and fine-smelling roses, all right? Like with pretty much everything we do in medicine, there is a downside. There are side effects that we need to be aware of. One of them, and you may have kind of intuited this when I showed you that cross-section of the alveoli a couple slides ago, where it stands to reason, if we're putting back pressure against here, which is kind of forcing more oxygen across these thin membranes into the bloodstream, are we preventing some of the carbon dioxide from coming out of the bloodstream? Turns out, yes, we are. Okay? Not lethally. Okay? We're not going to really hurt somebody by doing this. But remember when we had that range for carbon dioxide written up here before, which was what range? 45. If it's 48, what are we going to do to bring that back within range?
48?
Yeah. If it's high,
Slow down.
speed it up. Speed up respirations, you blow off more CO2. Okay? So we know how to correct that, is the point. You get your end titles out of range, we know how to correct it. The thing that it does that's pretty important, we're going to talk about this for a few minutes, is it creates intrathoracic pressures against the great vessels that can impede preload. It prevents some of the blood from getting back to the heart, which means now the heart doesn't have as much blood to pump out with each stroke, so it reduces your cardiac output. What vital sign are we going to see this reflected in?
Blood pressure.
Correct. And probably pulse is a compensation mechanism, but it's primarily blood pressure that's going to be affected. That's what we're afraid of. And I'll throw you a number, and this, don't write this down or take this as verbatim, but on average, you probably maybe see 15 to 20 millimeters of mercury change in your blood pressure by ventilating somebody at all, first of all, and second of all, by adding PEEP. So let's say we're dropping somebody's blood pressure by 15 to 20 points. Is that going to be a problem for everybody? Who's that going to be a problem for? People who are already in shock. Ding.
Everybody's in shock.
What?
Everybody is in shock.
Everybody's in shock all the time? I'm in shock?
Yep.
Are we being serious?
Number one reason that you die from.
Yeah, but I'm not dying.
Sure you are. If you live, you're dying.
Eventually, I'm going to be in shock, right? I'm just in a very slow, progressive state of shock. Yeah. I guess I feel like that, right? Now I am, right? Now I'm in shock. All right. Hypotensive patients, which isn't limited to people in shock, but I'll give you the star because that's where we should be going with this. So give me a hypotensive blood pressure.
60 over 40.
Okay, that's a bad blood pressure. Can I make it 65? I'm not comfortable with 60. Let's go 65 over 40. Now let's drop their blood pressure because we start ventilating them. Let's drop it by 15 points. What do we got? What are we left with? 50 over like 25. Okay. What's the difference between 65 over 40 and 50 over 25? Simply put.
15 points.
How about alive and dead? Okay. This person, are you likely to be able to feel a pulse on them at 65 over 40? Probably. Carotid pulse, maybe. Not going to be real strong. Probably going to be real fast, as Mark pointed out, because they're compensating, right? But this person who's 50 over 25, probably not going to feel it at all. Just the difference of a few points, all right? Which, again, we accomplished by ventilating them and adding PEEP. So people who are hypotensive, we need to be really cautious and aware of. What other subpopulation of patients do we need to be really cautious about dropping their blood pressure in? Yeah, there are definitely certain people with heart problems, probably because they're hypotensive. Now, these 65 over 40 could be from, shock from, it could be cardiogenic shock, it could be sepsis, could be from trauma, blood loss. Pediatrics who don't have a whole lot of blood pressure to begin with, but that's where they live, so they're okay with that, okay? Let me ask you this. If I told you your patient, or my patient, had a blood pressure of 110 over 70, would that be cool? You'd say that's good? Sure. What if I told you along the same line, the same patient was suffering from a traumatic brain injury, or TBI? Tell me, what threshold pressure do we want a patient with a closed head injury to have, according to your COGs?
Lowest as possible.
Not the lowest.
You want to stay at 90.
And we want everybody to be above 90, almost everybody. Below 90 for an adult, we call that hypotension. So that's a defining blood pressure that everybody should be aware of, 90 systolic, okay? But 90 systolic isn't enough for our head injured patients. So what does the COG tell us?
120.
Good guess?
2.
And you're close, but not there. 110 systolic, okay? So we want 110 systolic or greater for head injured patients. And why is that?
Because you want to keep the pressure to a minimum in their head so it doesn't raise the pressure.
You need more pressure in the skull in order to overcome the pressure that's accumulating in the skull from the injury or the insult. So whether you got blood accumulating in the space, like an epidural hematoma or a bunch of subdural hematomas, or you've got edema, just excess fluid accumulating in the space, now your circulatory system has to pound harder against that external pressure in order to perfuse what good brain tissue you got left. Say that again, Mark? To get blood to where it needs to go, to the brain. Okay, so they often have a higher blood pressure and need a higher blood pressure. So even though their 110 over 70 seems perfectly fine, we start ventilating them and adding PEEP, and that's going to likely drop their blood pressure, if it's this low already, to an unacceptably low level, okay, if they have a TBI. Now, for an opportunity for a star, and as just to kind of illustrate the spectrum of systolic blood pressures that we like people to have, is there anybody that we tolerate lower than a 90 systolic blood pressure in, other than a pediatric population, which again, they have lower blood pressures. We have a formula for that. It's in your COGs. I'm talking adult patients. Is there anybody that we're okay with them having less than 90 systolic? Who?
A person that has CHF.
No.
Because we're going to give them.
No, we still want them to be above 90. Yeah. Any other thoughts? Who would we tolerate less than a 90 systolic, and what would the pressure be? How about traumatic non-compressible bleeds? Yeah, there you go. You were going there. Right. So permissive hypotension, right? In an internal bleed trauma patient, we can't get in there and stop the bleeding. So we don't necessarily want to deliberately bring their pressure up to 90 if it's low to begin with, because low might be okay if we just force a bunch of crystalloid IV fluid in there. Then we're just making them bleed more internally, blowing out clots and making them bleed Kool-Aid instead of, what they would normally bleed. So we're just filling a void with a bunch of pink fluid. What pressure do we tolerate in the trauma non-compressible bleed patients? Look it up in your COGs. Let me know when you find it, and I'll move on. Okay. So that was just an aside to get you going in and out of the COGs. So we'll table that for now. Let me know when you come up with an answer. So we need to be aware that ventilating alone causes a drop in blood pressure. Ventilating with PEEP can drop it even more. All right? 70, that is correct. 70 systolic. Who was that, Logan? All right. Give you that for finding it first. Logan is pulling ahead here by a... Okay. Yeah, I had to get the biggest phone possible so that I could read the COGs, and I still need glasses. All right. So this slide just kind of summarizes what I just said, which is that changing from negative pressure ventilation to positive pressure ventilation can have a profound hemodynamic change. This can be fatal in the hemodynamically sensitive patient, in the hypotensive patient. Can cause irreparable brain damage in the brain-injured patient. Fluid and pressure support might be necessary prior to intubation. Okay, so let's look at some statistics on this, because this is important. This is something that we've learned a whole lot more about in the last 10 to 15 years. And we didn't understand this. In the 30 years I've been doing EMS, we were not doing this when I started. Even when I started as a paramedic about 20 years ago, people were not emphasizing the importance of maintaining blood pressure and oxygen saturation in the brain-injured patient pre-hospitally. For that reason, people like me were getting on scene with, GCS3 head-injured patients. I didn't care what their blood pressure was. I didn't care what their sat was. I cared that I got a tube in. And I don't know how much brain matter I wasted by doing that. Because here's what we need to do. We need to ventilate them first, and we need to maintain their blood pressure. Before we get to that, let's talk about why. So in retrospective study of patients with traumatic brain injury who had a GCS score of 12 or less. How low is 12?
Not very low.
It's really not very low. What's the range for GCS? 3 to 15. Everybody gets a 3 just for showing up to the party. They could dig you up out of the ground, you got a GCS of 3, okay? 15 being the high end, 12 is not all that low in the grand scheme of things. It's sick. You take a point off each category. It would be somebody who, verbally isn't conjugating their verbs, like isn't speaking eloquently, isn't conscious, so they'll respond to verbal stimuli, but they're not awake and looking at you. And then motor-wise doesn't follow commands, but still has purposeful movement. They'll push you away if you cause them pain or something like that. So GCS of 12. What GCS does somebody have who is really sick, say from a traumatic brain injury?
5, 6.
That'd be really sick. What's kind of the cutoff threshold that we've talked about for years in EMS of GCS of this level, GCS less than 8, and?
Less than 9.
Yeah, less than 9, or 8 or less. GCS of 8, intubate was what we used to talk about. We don't talk about that anymore because not everybody with a GCS of 8 or less needs to be intubated, first of all. It was also brought to my attention in one of the classes last week that GCS was 8 was the magic verbiage that you use over the radio to make sure you're getting Starflight to come. Tell them they have GCS of 8. That's a sick patient. Okay, launch Starflight. So in any case, point is GCS of 12, not all that low. You could go a lot lower. Nevertheless, we take that patient with a GCS of 12 and just within the first 24 hours of admission to the hospital, we let them get hypotensive for just a few minutes. That's only a systolic less than 90. Or hypoxic. Let's talk about the hypotension. The ones we allowed to get hypotensive for a few minutes, 65% of them died. If we let it happen twice, that mortality rate increases 4-fold. And that's just mortality. That's just the number who died as a result of that hypotensive episode or 2 hypotensive episodes. That's not talking about the patients who lived, who got discharged from the ICU and couldn't do first-grade math anymore. Or worse than that, were basically a Cabbage Patch candidate the rest of their lives. Or the children who never made it beyond first-grade math because of the damage to their brain. Okay? So we got to prevent hypotension. That's why we need to understand what PEEP can do, what ventilations do when we start ventilating somebody. We need to manage their blood pressure. How can we manage their blood pressure if they're hypotensive and we need to ventilate them? we can give them IV fluids, okay, if we need to maintain a reasonable blood pressure level. Now, we still have to ventilate them. Just because we're worried about hypotension doesn't mean that, oh, we shouldn't ventilate them, because of those who had a hypoxic episode for about the same amount of time, just a few minutes, 44% of them died. So we got to keep brain injured patients from becoming hypotensive or hypoxic, and we have not been doing that very well. Patients get hypotensive and hypoxic anytime you try to intubate them.
Yeah, because you cut off everything, they put the intubation tools into place.
Yeah, you've taken over their respiratory drive. If you haven't pre-oxygenated them, they're going to desat real fast. And that positive pressure and that PEEP causes a reduction in blood pressure, not to mention the drugs that we give them in order to facilitate the intubation. So we have got to be more aware of this. We've got to be better at managing it. And we are, at Starflight, for instance, now, we have a specific protocol that targets this, that prevents us, that causes us to manage the hypotensive or the hypoxic patient before we intubate them, and prevents them from getting hypotensive or hypoxic as a result of us trying to intubate. And if we look at that, we break it down to nasal cannula at high flow. And this is new. Is this new information for anybody right now today? Was this the first time you ever saw nasal cannula at 15 liters per minute? Okay, so this is new. This is new in your COGs. It's a relatively new approach. It is not limited to us here in this room. It is not limited to Travis County. It is not limited to Starflight. This is being done. And several physicians have their name on this with data published indicating that this extra oxygen that you're adding with the nasal cannula can make an enormous difference at preventing hypoxia as you're trying to take over their airway. Why do you think a nasal cannula, and we're going to add a BVM to this, but before we get there, why is the nasal cannula so important for increasing oxygen?
Well, if the patient is unconscious, tongue or other things may be getting in the way of the BVM, and nasal cannula bypasses at least the tongue, way upper respiratory or upper airway.
Yep.
Gets where it needs to be.
Yep, I'll give you that, Mark. That's a good one. And another thing that sort of is, I guess it's implicit in what you said, but I'm just going to add to that, to say that nasal cavity where you're bypassing, the back of that tongue, it's also just a huge space, right? And if it's not filled with 100% oxygen, what's it filled with? A bunch of nitrogen, some carbon dioxide, some helium and argon or whatever other gases that aren't doing us any good. So if we replace that big cavity with a bunch of oxygen, that is washing it out, okay? Now that volume of oxygen is ready to get bagged in when you squeeze that BVM. So that's what we're accomplishing with the nasal cannula. Then the BVM on top of that, so you got 15 liters going in by nasal cannula, you got 15 to 25 going in with the BVM, using them at the same time, BVM right over the nasal cannula. That, along with your basic airway adjuncts, suction as needed, head positioning, and PEEP at up to 10 centimeters of water, and 2 pairs of hands, okay? That's all in your BLS package. You have all that. Okay, and we're going to practice that next door. But that equipment and using it, that's good BLS airway management, and that may be that's all that's necessary. Most of the time it will be all that's necessary to bring their SATs up above 94%, which is the target, for at least 3 minutes. Okay? If you've done that, and that's what it says here at the bottom of the slide, if you've done that, then you have made them a safe candidate for intubation, if intubation is required still. Because here's the thing. If you've done this, you guys have all the tools necessary, you have the know-how, you have demonstrated that their airway can be managed with BLS tools. So it may not be necessary to intubate the patient.
It smells like it's going to wait 30 minutes to try to intubate.
I would hope not.
It happened.
I know it happened. I know it happens. It should be happening a whole lot less now. Okay, because first of all, every time we decide to intubate a patient on scene, we know we're costing them at least 8 to 10 more minutes of scene time, just because of everything that needs to happen. Get your tools out, get them ready, pre-oxygenate, intubate, confirm the tube, secure the tube, start ventilating, move them to the aircraft. That's at least 8 minutes. I don't care who do. I don't care how fast you are, how good you are. If they do need to be intubated, and some patients will still need to be intubated, okay, that's a clinical judgment. If you guys have done all this, you've cut that time at least in half. You've bought that patient 3 or 4 minutes minimum faster getting to a trauma center. by taking care of all this ahead of time. Plus, you've prevented them from desaturating, you've preserved brain tissue, like you've kept the patient alive, which is hopefully what we're doing for our patients whenever possible. Okay, so let me go back a couple of slides first. So basically what this says is that, yeah, 94% for 3 minutes. If you need to insert a supraglottic device in order to do that, you would add that to your toolbox, or pull that out of your toolbox, add that to your bag of tricks. So now let's talk about the oxyhemoglobin dissociation curve. The heck is that? Oxyhemoglobin dissociation curve is just a slippery slope. Don't overcomplicate it. Don't think of it in any more complicated terms than that. It's a very slippery slope for patients that when we take over their airway and we start trying to intubate them, they're going to desaturate. We take away their intrinsic respiratory drive, and if we have not pre-oxygenated them enough ahead of time, they're going to start desaturating really, really fast. I mean, that's what it comes down to. So if we take somebody with a SAT of 90, okay, that's this level here. So the x-axis is oxygen saturation, which we're all familiar with. The y-axis here is PaO2, or the amount of oxygen dissolved into their blood. If they only got a SAT of 90, they only got so much oxygen dissolved into their blood, and they just don't have any reserve to tolerate not breathing for any length of time. They'll start desaturating immediately. And we already saw what happens to the brain-injured patient if they start desaturating just below 92%. Do you guys remember what the mortality rate was for that? 44%. Yeah, and then it increases with each additional hypoxic episode or the amount of time that you let them be hypoxic. So we got to get their SATs well above 90. Okay, 94 is our minimum goal. In this case, I would not be afraid of saturating somebody to 100% if I'm deliberately pre-oxygenating them for a potential advanced airway, for an endotracheal intubation attempt. Get their SATs up. The more you saturate them and hypersaturate them, the longer you buy them of time that they can sit and not be breathing before they start desaturating. You know, in the OR, when they prep patients for surgery, they do this. And they get somebody so oxygenated that they can walk away from them, leave them on the table not breathing, and they won't desaturate for minutes. Like 7 or 8 minutes. We can't do that with our patients in the field. We wouldn't do that, first of all, even if we could. But if we walk away from somebody with PaO2 of 90 for a few seconds, they're going to desaturate. We want to try to oxygenate them to that point where they've got that much reserve before they start desaturating. That's just us extending the slippery slope, so it's just not so slippery. Okay? That's what the oxyhemoglobin dissociation curve is all about. Questions on that?
So that bottom axis you're saying is just the percent of oxygen that's actually in the blood?
It's not percent, it's actually dissolved gases, so it's partial pressures of oxygen. And so what it amounts to, you don't know what it is in the field because you can't measure it in the field the way you can pulse oximetry. So it's an extrapolation, it's a guess basically of if we got a saturation of this, we know that most people have this many parts per million or partial pressures of gases dissolved into their blood. Because when oxygen doesn't have hemoglobin to attach to anymore, basically when you've saturated 100% of the hemoglobin, but you're still forcing it in, especially under pressure, it's got to go somewhere, so it just dissolves in the blood plasma. And it hangs out there in the blood plasma kind of waiting, and just can't wait. Every oxygen molecule wants a hemoglobin, and as soon as a hemoglobin opens up because it hands off oxygen to a cell that needed it, now there's oxygen right there in the plasma to take its place. And that's what increasing the oxygen dissolved in the blood plasma or the partial pressure of oxygen will do for us. Good question. Does that make sense?
Yeah.
Okay. Other questions on this? Okay. Well, that concludes the lecture portion, and we'll go next door now and practice.